Slide type bracket. I would like to introduce the slide type bracket, which facilitates occlusal approximation of the premolar in orthodontics. Why is the slide type bracket used? I would like to introduce the slide type bracket, which facilitates occlusal approximation of the premolar in orthodontics. Many orthodontists have experienced improper occlusion of the premolar in spite of placing a bracket on the patient's premolar surface using a jig or a gauge. In such cases, frequent reset of the bracket and wire was too annoying. It was impossible to determine how much bracket shift is required for the desired premolar occlusion. Also, after reset of the bracket, unnoticed premature contact or slight malocclusion may occur and may contribute to major stresses in orthodontic treatment. Every time the bracket is reset, repetitive polishing and etching may also damage the tooth surface. One of the various causes preventing the premolar from attaining normal occlusion through orthodontic treatment seems to be the vague position of the buccal tube on the first molar surface. Consequently, successful set of the bracket position for premolars requires good experience and considerable skill. An apparatus that allows for correcting the vague position of the buccal tube is also needed in order to obtain reliable results. The slide type bracket has been designed to resolve these problems. I have provided orthodontic treatment with a tip edge technique. However, the slide type bracket provides significant merits with the edgewise technique. The technique is described here with respective figures. Outline of the slide type bracket, Volume 1. The slide type bracket consists of a sliding plate and a bracket with a sliding apparatus. The sliding plate has a bonding plate in accordance with the tooth surface, U-shaped rail, hooks, and stoppers to prevent detachment of the bracket. It also has a median line that accords with the bracket. When a wire is placed into the bracket slot at the cervical area, the bracket should be linearly arranged in accordance with the long axis of the tooth to avoid high torque. Outline of the slide type bracket, Volume 2. The bracket includes a rod or plate sliding apparatus, which is inserted into the rail of the sliding plate, and the stopper is closed to prevent the sliding apparatus from detaching. The bracket smoothly slides into the rail without backlashes. The distance from the tooth surface of the wire slot to the base of bracket slot, use of the vertical slot pin and the spring are the same as with conventional brackets. This allows intrusion, extrusion, upright, and mesial or distal movements of the premolar as angulation is provided to the bracket. The premolar can be intruded or extruded by itself without replacement of the bracket and wire, which facilitates occlusal adjustment. A fixation apparatus for fixing a bracket, provided at the center of the sliding plate, allows usual use of the bracket with a jig or a gauge. The functions previously mentioned can be fulfilled by detaching the fixation apparatus as needed. Examples of how the slide type bracket is used. Intrusion of the premolar can be performed by attaching a ligature wire to the occlusal hook of the sliding plate and the cervical hook of the bracket, followed by proper tension application. Extrusion can be performed by attaching a ligature wire to the opposite hooks, followed by pressure application. The addition of abnormal forces during eating may cause the ligature wire to detach due to sliding of the bracket. Consequently, the ligature wire should be attached in the extruding direction during intrusion or in the intruding direction during extrusion and should be slightly fixed. When occlusion of the premolar is abnormal during closure of the interdental space, the higher level premolar than the ideal occlusal plane should be first intruded to align it with the ideal occlusal plane. The ligature wire is then detached to fix the bracket. For bracket fixation, a high flowable resin is injected into the gap between the bracket and the sliding plate from both the occlusal side and the cervical side. The patient is placed in a horizontal or temporal position, taking the bracket weight into consideration to set the resin, while verifying that the bracket is neutral without deflection of the wire. Fixation is thus completed. Fixation with the resin rather than with the ligature wire produces less margin of error and is more reliable. The lower premolar is then extruded. A slight clearance with the opposite premolar allows natural extrusion. With more clearance, an extrusion close to the distance is provided to remove the ligature wire and wait for natural extrusion of the premolar until occlusion is established. The bracket is fixed, as previously mentioned, after verification of occlusion. Fixation should be performed with secure occlusion. With premature contact, the upper-lower premolars are once intruded, followed by performing occlusal adjustment through procedures previously mentioned. Similar occlusal adjustment is also possible in non-extraction cases. Cases of deep bite or scissors bite. For patients with deep overbite or scissors bite, after the fixation apparatus is detached, during attachment of the bracket, sliding the bracket up to the position without interference to fix it with a ligature wire allows minimum interference with the opposite tooth and prevents the bracket from detaching. After improvement in occlusion, removal of the ligature wire and reset of the fixation apparatus allow orthodontic treatment as usual. The slide type bracket is applicable to most brackets available worldwide. With the tip edge technique. With the tip edge technique, uprighting of the premolar is achieved after closing the space with tipping movement. Since occlusal adjustment before uprighting may cause subtle changes in occlusion afterwards, occlusal adjustment should be performed simultaneously or after uprighting. The speed of intrusion or extrusion seems to be slower than that of the edgewise technique due to the use of a sidewinder spring or a nitinol wire in the tip edge plus. A slight clearance between both premolars allows elimination of torsion and alignment. This is because the premolars can be treated orthodontically at the early stage, as well as occlusion correction during retention with a pre-finisher. If crowding of the premolars is confirmed at initiation of orthodontic treatment, intrusion or extrusion can begin. The occlusion can be corrected at the final stage. Concerning the patent, the slide type bracket has already acquired a Japanese patent and a United States patent. Under normal circumstances, I have to report the experimental results clinically or in a typodont using a prototype model of the slide type bracket. Since significant expenditures are required to produce the prototype, I have not yet started on one. I am convinced that commercialization of the slide type bracket will be good news for orthodontists and patients needing orthodontic treatment both in Japan and abroad. I hope that using the slide type bracket allows everyone to conduct more reliable orthodontic treatment without stress.